Welcome to the Egg Whisperers Show. Today we're going to talk about detecting cancer early, how GRAIL's technology can help with Trudy McKanna. So, one of the biggest fears my patients have is about their risk of long term effects from being a fertility patient, from all the medications that they take. And in this episode, I talk with Trudy McKanna from GRAIL about how their groundbreaking Galleri test is changing the game in early cancer detection. Welcome, Trudy. Thank you for joining me.
Thanks for having me.
I'm going to tell you a little bit more about Trudy. She is a senior field medical director at GRAIL, specializing in genetic counseling and medical affairs. Previously, she spent 9 years at Natera, leading medical education and clinical initiatives in transplant and renal genetics. She holds a master's in genetic counseling from the University of Michigan, also my alma mater, and has extensive experience in genetic research, education, and patient advocacy. For folks who don't know about GRAIL, tell us a little bit about it and the company's mission.
Thanks, Amy. So, GRAIL's mission is to detect cancer early when it can be cured. So, this is a lofty mission. It's not something we're saying we've achieved yet, but we're saying this is something that we think is possible with new technology. We have one product on the market that's been available for about 4 years. It launched in June 2021 called Galleri. The company was actually formed in a really interesting way from an unexpected discovery in the prenatal space. So, our former parent company was offering prenatal genetic screening called non invasive prenatal testing, or NIPT, which you may be familiar with. And this is a test where you can draw blood from mom and screen the pregnant woman to see if there are certain genetic conditions in the baby. In doing 100,000 plus of these tests, they found about 10 women where they just couldn't interpret the results. And unfortunately, what they found in those women is either during their pregnancy or pretty soon after delivery, they were diagnosed with cancer and different types of cancer. And so that was kind of the aha moment of when they were looking for one thing, they actually found something else. And not only did they realize we can find evidence of cancer in the blood before anybody has symptoms, but it wasn't even related to one type of cancer. It could be multiple different kinds of cancer.
That's like a dream come true for a doctor like me, where you want to do everything in your power to give patients knowledge before they even start a pregnancy.
Yeah.
And also for patients who've done like 6, 7, 9 rounds of IVF, 10 years from now, when they're, let's say, in their 50s, when they're wondering, I wonder if all those cycles put me at risk for cancer, then maybe they could be doing this test.
Exactly.
And this test can detect over 50 cancers before symptoms appear. How does the technology work? I mean, you mentioned it's a blood draw, but how does it work and why is it a game changer for early cancer detection?
Yeah, so I mentioned how the origin story was from non-invasive prenatal testing. And in that screen, what you're looking at is cell-free DNA. So everybody has cell-free DNA, which is just little pieces of DNA from your cells as they die and they're circulating in your blood. If you are pregnant, then the baby was also emitting cell-free DNA. That's what the NIPT test was doing. But cancer also can be having cells that die and emit cell-free DNA into the circulation. And so this is what we're looking at when we draw the blood is we say, okay, can we remove everybody else's cell-free DNA that we're expecting to see from you? But do we also see essentially a fingerprint of cancer DNA? So cancer cells are cancerous because they can't stop growing. They're missing all of those normal cell functions to tell it to stop dividing. And that actually has a unique fingerprint that we can detect in the body if there's enough cell-free DNA from a tumor in circulation. And it really is a game changer because this allows us to screen asymptomatic healthy people for any type of cancer, not a single type, because all different cancers should have that underlying fingerprint.
When someone gets a cancer diagnosis, I mean, that's really scary. And I think what people don't realize is most cancers are survivable if you catch them early enough. So tell us more about that. How does early cancer detection change the trajectory of treatment and survival rate?
Everybody is very familiar with the, I think, 5 single cancer screenings that we have available now at certain ages or certain risk factors. So mammography for breast cancer, colonoscopy for colon cancer, cervical cancer screening with pap smears, and then for certain individuals, low dose CT for lung cancer and prostate screening cancer with PSA. So the idea of screening for single cancers early because we can change the trajectory of that treatment has been around for a long time. Unfortunately, though, it's been limited to those 5 cancers, which only account for about 30% of all cancer. What about the other 70% that we can't screen for? We're waiting for symptoms to develop or something else to come up. So now we're able to look for cancers early. And studies have shown that the 5 year survival rate for early stage cancer is about 89%. But, and like you mentioned, it definitely goes down as you're diagnosed after that cancer's had a chance to spread. That 5 year survival rate is about 21%. So, about a fourfold increased survival rate when you can catch that cancer early.
In general, how much earlier does the GRAIL test allow someone to know they may have cancer? And I'm sure it's a hard question to answer because it just, you never know. I mean, it might take years until someone finally has symptoms from like a stage 3 or stage 4 ovarian cancer.
But the Galleri test, we call it a multi-cancer early detection test. What exactly does early mean? And early oftentimes may just mean that it's before symptoms arise. So before somebody is presenting into the ER with symptoms that get diagnosed with a late stage cancer, we want to detect it as early as possible. And one of the best ways to do that is really integrating this into routine care so that you're screening all the time. So those more aggressive cancers, those quicker growing cancers, don't have time to kind of sneak up on people.
So Trudy, for someone who like has no science background, what is the Galleri test?
Galleri test is a multi-cancer early detection test, or MCED test. If you break it down into its components, that it describes exactly what it is. It is a multi-cancer, so it's screening for a number of different cancers, which is different from current single cancer screens. This is a screening for multiple cancers early, and early can be subjective. It's usually what we're thinking is it's earlier than you would normally be diagnosed, so before symptoms develop, and then early detection. So we are screening for multiple cancers to find them as early as possible.
And it's just a simple blood test.
Just a simple blood test.
I mean, that's just groundbreaking. It's mind blowing for me that we're at that point in medicine that we can have a test like this. And I'm just so glad that you're coming on to talk to us about it. And then, how accurate is the test in predicting the origin of a detected cancer? How does that guide next steps in diagnosis and treatment?
Yeah, it's a great question and a really important part of what multi-cancer early detection tests should have as a fundamental piece of their benefit is we don't want to do a test that just says we see a potential signal or potential fingerprint of cancer, go find it. That's kind of scary to get any kind of result like that. But if there's no diagnosis path that's clear, that can also add to that anxiety. What GRAIL does is we're able to narrow down the cancer signal origin, or CSO, with about 93% accuracy. So we can say, we did see that fingerprint of cancer in your blood, and it looks like it's coming from one of these 18 different areas. So that kind of helps that patient and the provider organize that follow-up screening much more efficiently.
Yeah. And this gives patients time to make plans and it gives them options. There was an article in the Atlanta Journal Constitution. They looked into new genetic sequencing technologies that detect minimal residual disease, or MRD, in cancer patients, potentially reducing the need for chemotherapy. How does GRAIL's Galleri test align with these advancements? And what implications could this have for fertility preservation in patients who might avoid chemo?
So MCED is a pre-diagnostic test. So patients don't have cancer yet. MCED can help detect that cancer ideally earlier. And then the MRD test can then take that patient the rest of the way through their cancer journey. Like you said, understanding how the cancer is behaving before surgery, after surgery, and onward. Well, they're actually quite different tests, but they really both are brand new tests that work in that cancer care continuum and really have changed the trajectory of a cancer diagnosis. What does that mean? There are so many more tools available. In my mind, the ideal cancer diagnosis path in the future, and hopefully the not too distant future, is you use a multi-cancer early detection test to have a cancer diagnosed earlier, where you have much more simple treatment options like surgical resection or something that could avoid chemotherapy. MRD allows the patient and the provider to feel comfortable with where that journey is going. And then after treatment is over at an appropriate time, restarting the Galleri test, the MCED test, to say, let's not just look for the one cancer that we did find for recurrence, but let's also remember that there are other cancers that could happen. We want to continue screening for all of those long term as well.
How often should someone be doing the Galleri test? I mean, I imagine you do it once. Should you do it again 5 years later, 10 years later? What's the regular interval that someone should be doing it?
That's a great question. And one we get asked pretty much every time we are talking about MCED testing. And it's a great point to make that the day you draw your blood for an MCED, it's only looking at, do we find that cancer signal in your blood that day? And so that means that you have to have a cancer that is growing and emitting cell-free DNA into your blood on that blood draw day. And so we can have also false negatives where it could miss a cancer because it's still too early. Doesn't have access to the bloodstream yet, or it hasn't developed yet. So we did a number of studies, both modeling studies and real world data studies, looking at people who had our test over a couple of years, and also another study with the American Cancer Society, and said the most appropriate time if you want to detect the most number of cancers is an annual basis, because those fastest growing, most aggressive cancers can have a dwell time of under a year. So you could have a clean bill of health January of this year, and worst case scenario is one of those cancers is developing, and you want to catch it as early as possible. Now, because it's not covered by insurance, it could be something where people make a different financial decision, but annually is a reasonable cadence. And it also works well with just normal annual physical screens that you're going in.
Right.
And that's, I think, ultimately what our goal would be, is to have that integrated into annual physicals. This is part of your cancer piece of your annual screen.
Because cancer is so common. It just makes sense. I worry about patients who are mine who've, let's say, come to me after a journey of 6, 7, 8 IVF cycles, and they still want to do 3, 4, 5 more, and all the hormones they've been on, especially in patients who've taken a medication called Clomid. So there might be an increased risk of ovarian cancer associated with Clomid. There was a study published in August of 2024 titled Fertility Drugs and Cancer, and it was a nice summary about the risks from these drugs. And so I feel like fertility doctors need to know about this test. And I think it should be part of our counseling, saying, look, like after your journey, maybe in 10 years, start doing the Galleri test on a, I don't know, maybe annual basis or every 3 to 5 years, something like that. But one of the barriers to these kinds of tests is like doctors, we know about the NIPTs, right? So, how do we get more doctors to know about this test?
Well, hopefully things like today's podcast are one of the things that we can do to help spread the word. What we're finding a lot is patients are coming to their doctors, and maybe it's the primary care provider, maybe it's their fertility specialist, someone else, to say, I heard about this test from any number of sources. I'd like to learn more information. So sometimes, and not rarely, patients are actually educating their providers. I also have a team of medical science liaisons, so medical professionals across the country whose entire job it is to go out and educate healthcare providers, to tell them about our studies, to tell about the validation. Like you mentioned earlier, it almost sounds too good to be true. And understandably, that can be a healthcare provider's first reaction if they haven't heard of it. But we have the data that we can show to say this is not something that doesn't have scientific rigor behind it. You're aware of NIPT. It's using the same technology that's been around for decades. It's just a new application, a really fantastic application, and here's where it is. So definitely you hit the nail on the head of this test. We want to be able to be in the hands of as many people as possible, and education and awareness is the number one goal to get there.
Yeah, well said. And then can patients ask for this test now? I mean, I know my patients can, but what if there's a patient at another clinic? How can they get the test if they want it?
There's a couple different ways. And at the end of the day, we recommend that no matter what your situation is, you talk to your healthcare provider about your risks for cancer. There are certain things, like you've mentioned, with the fertility meds, a personal history or family history of cancer, kind of looking at that holistic person and their age at the end of the day, because all of those things, like you mentioned before, have an additive effect as you age. Over time, that risk for cancer is going to increase. So it's a very personal choice when somebody wants to get tested. It's also a financial decision. Right now, most insurances are not covering it. So it's something where talking to your healthcare provider about your risks, your specific experiences, to look at overall is this test right for you right now, would be the first step. One of the ways that people can find out more information, though, is on our website, galleri.com. There is a patient resource center and a very comprehensive amount of information for patients and also for providers if they wanted to direct their providers to that testing.
Yeah. And what if there's a patient who's on the fence and not sure if they want to do the test or not? What would you say to them?
Yeah, that's a great question. And again, I think it just goes back to personal choice. We have a lot of programs where it's covered by, say, an employer, and you'll hear people, very differently say, oh, I want to know as soon as possible, and other people who don't want to know. And so it's something that nobody can make the decision for you. You have to really just look at what are the risks and what are the benefits. And one of the things that we do consider in screening younger patients is all screening tests like this have false positives. They're not a diagnostic test. It can come back and say, we saw a fingerprint for cancer and a workup does not find cancer. So we want to weigh the risks of the anxiety of that and the workups that would follow to do that versus the absolute risk for cancer. And everybody has to make their own choice on that.
Yeah. And what about someone who feels healthy and has no symptoms? Is this a test that could help them?
That's really our target population. Again, people who are at an increased risk of cancer, such as those age 50 and older, but could have other risk factors, who are asymptomatic, who before were waiting for those symptoms or those non-specific symptoms, that we are catching this as part of routine screening.
And I just want to make it clear that my podcast, nothing on my show is ever sponsored. So no companies reach out to me to say, hey, we want to plug this product. I find people that I think are going to change the world and make this world a better, healthier place. And that's why I reached out to Galleri and I said, I need to learn more about your test. I want to talk to you. I want to have patients who are curious about whether this could be for them to find out more. Trudy, is there anything else you'd like to add today?
I think just at the end of the day, everyone has a story about cancer, either a personal story, family history, friends affected. So this is something that really does have the potential to change everyone's lives, whether it's your own diagnosis of cancer or a loved one. And so thank you today for the opportunity to explore this new development of multi-cancer early detection and to increase that awareness so that we can continue to have that impact on the public.